Hello everyone, my name is Berta Raventós. I'm a predoctoral researcher from IDIAP, Jordi. I'm going to briefly present one of our recent publications in which we described how we map the SIDIAP data to the OMOP common data model and its use for COVID-19 research. Okay. So, as many of you know, the SIDIAP database contains primary care electronic health records from Catalonia, Spain. We have approximately 6 million people active, which correspond to 75% of the Catalan population. The SIDIAP database is representative of the population living in Catalonia in terms of age, sex, and geographic distribution, and has a wide range of clinical and sociodemographic variables. The SIDIAP database is particularly unique because it's possible to link the primary care data to hospital data, and this is something that is very, very useful when performing COVID-19 research. Therefore, the objectives of our study were to convert the SIDIAP data to the OMOP common data model to facilitate distributed network research and to summarize the current of COVID-19 related outcomes and describe the characteristics of those affected and vaccinated against the disease to show its potential to perform meaningful and timely evidence. So in order to map our data, we followed an extract, transform, and load process that involved several steps. And for many of those, we use OHDSI tools such as the White Rabbit tool or the Data Quality Dashboard R package. We implemented the OMOP version 5.3, and we use Postgres as a database management system. In terms of COVID-19, we identify non-hospitalized individuals that were registered in the database as of March 2020, and we followed them up until June 2022. We did a descriptive analysis in which we summarized the characteristics of the population in the general population and the population that had COVID in terms of demographic characteristics, comorbidities, and symptoms. In terms of the outcomes that we were interested in, we wanted to look at outpatient cases, and to do so we used different definitions. Some of them were based on clinical diagnostic codes, and others were based on tests such as PCR or antigen tests. We also look at hospitalizations, admissions to ICU, or deaths with COVID-19. And because we don't have the exact cause of hospitalization or death, we had to establish different time windows in order to ascertain whether there was a potential connection between COVID-19 infection and the reported hospitalization or death. And lastly, we also looked at vaccination against COVID-19. And to do so, we look at the first dose of any of the vaccines available in Spain, that were Pfizer, AstraZeneca, Moderna, or Janssen. So in terms of the results, we map over 90% of terms and registers of the main tables of the CDM, and we also run almost 3,500 quality checks, and of those, almost 99% of those passed. In terms of COVID-19, these are the number of people that were included in each of the cohorts we considered. As you can see, we had almost 6 million people in the general population, and we were able to capture 4.5 million people that were vaccinated against COVID-19, and a high number of people who had COVID or were hospitalized or admitted to ICU because of COVID. We also saw that people who experienced more severe COVID-19 outcomes were more commonly male, older, and had more comorbidities. However, I'm not going to talk about all the details, but you can check all the characterization in the paper. We also plot counts of cases over time, stratified by cohort and by age group, and we saw how the SIDIAP database was able to capture very well the different pandemic waves that we had in Spain. And as you can see, we saw that during the first pandemic wave, there was a high number of COVID-19 hospitalizations and deaths, especially among the older age group, and how they diminished over time. We also saw how the sixth pandemic wave affected young people. This corresponds to the Omicron variable and caused a lot of outpatient cases. In terms of the impact of using different COVID-19 definitions, we saw how using a definition that included clinical codes was particularly useful to capture cases during the first pandemic wave when testing was not available, and therefore we conclude that having a definition that includes both testing and diagnosis would be particularly useful to capture most of those cases. And we also saw that symptoms were poorly recorded. In fact, the prevalence of symptoms 2 days before or after a diagnosis or a positive test were less than 6% and has had substantial changes over time. So lastly, in terms of strengths and limitations, say that SIDIAP database is very unique because it captures a lot of different data, and it can capture outcomes both in both outpatient and inpatient care settings. We have complete COVID-19 registers in terms of testings and vaccinations done in the public health systems, and this means we can capture a lot of the health interactions that patients have with their GP. And as limitations, we obviously have some underreporting of cases and symptoms. And even though we have the diagnostics and procedures that are done within a hospitalization, we lack information about the prescriptions and tests that are done within this hospitalization. And we also lack the cause of death. For those who want to use IDIAP database to perform COVID-19 research, it's important to consider that since March 2022, COVID-19 testing is restricted to specific subgroups, such as the elderly or pregnant women, and therefore there will be some risk of misclassification. And as a conclusion, say that we have successfully harmonized the SIDIAP database to the OMOP common data model, and we have illustrated its potential to perform COVID-19 distributed network research. In fact, over the last 2 or 3 years, we have been able to use this database and to publish over 20 studies. And say that we have, in this paper, we have provided some insights regarding important considerations for future research in our setting, including the impact of different outpatient COVID-19 definition and significant testing-related information. And lastly, just to say thank you to all the people that were involved in this paper, and especially those who were involved in the mapping of the data and the funders of this study. So thank you very much.